I was about to say good afternoon, but it's still morning. So good morning, everybody. How's everybody doing today? Blessed and highly favored? Anybody blessed and highly favored in here? Make some noise. Anybody that love the Lord, make some noise for me right now. Well, I am going to definitely listen to our esteemed guest today because as a young man, I lost my dad at 19 years old to lung cancer. And tomorrow is my 60th birthday. Good black don't crack, do it. All right now. All right now, you heard me. So let me introduce our esteemed guest. Lung cancer affects black Americans, particularly black men, differently than their white counterparts. African American men are 11% more likely to be diagnosed with lung cancer, and 9.8% more Americans men die from the disease than their white counterparts. Joining us for a discussion about being aware of the symptoms is Dr. Eric Flannel. Dr. Flannel completed his pulmonary training at UTHSC Houston and MD Anderson Cancer Center, which included a formal training curriculum in advanced diagnostic and interventional pulmonary medicine. As part of the Grady Health System faculty, any Grady babies in here? All right, holla at your boy now. He has performed grant-funded and award-winning research published in peer-reviewed journals, authored book chapters, served on multiple hospital committees, established clinical service lines with development of practice guidelines for the screening and diagnosis of lung cancer, and performed skills assessments and didactic teaching for physicians and health centers nationally and internationally. That is a mouthful, and he deserves your applause. Welcome, Dr. Eric Flannel, please.
Thank you for having me. Just make sure this works. Now, I'm going to pull up the slides. Okay, great. So I think forums like this are extremely important because it focuses on health equity. And we cannot achieve health equity if we do not achieve health literacy. And that is making sure that people are empowered with knowledge of their health diseases and treatments that are available to them or that affect them, and can voice this to the healthcare professionals and facilities to make sure they're getting equal care. So it's really important, and thank you for having me for this, and I hope that you guys continue to do this. Now, lung cancer has been something that I've been very interested in since I've started my career, especially here at Grady, 23 years. And I'm going to warn the faculty here, I always run long. So if I'm running long, you either flag me down and say, hey, wrap it up, or I'm going to keep going, okay? All right, because I think this is very important. What people don't realize is that lung cancer affects African Americans a lot worse than they really think it does. And they always think, when you start talking about disparities, people start thinking, okay, it's race, it's genetics, it's all this aspect. Or when you start talking about lung cancer, they think it's smoking alone. But I want to take the disparities, these differences, and think of it in two different realms. And it's what I'm showing right here. One, think about it about the health, okay? And those factors which influence health, which is environmental or biology. So an example, environmental would be smoking or exposure to radon, which is very prevalent. And you know, even here in Georgia, you have to have your house tested for radon, right? Which is the #2 leading cause of lung cancer here, second to smoking, okay? And the other part is biology. And it's not just so much of, am I more susceptible or whatever else? There's two aspects of it, right? Because you have some people who may have never smoked, right? But they still get lung cancer. And then you have other people who don't smoke nearly as much, and we're going to talk about that a little bit. But their rates of lung cancer, especially of African Americans, is much higher. And then the other aspect is healthcare, right? Early detection and systemic factors of the treatment, of the staging, of the diagnosis is the systemic factors, and the early detection. And early detection is two parts. What your hospital facility or your physician offers for it to be detected early. And the other aspect of it is, and especially us black men, going to the doctor, right? Okay, all right, I'm gonna say because I'm one of them, okay? Yeah, we're okay. So let's talk about the environmental factors here in health as it plays a role. So African Americans, they have the highest U.S. lung cancer mortality rate despite similar smoking rates to whites. Okay, I want you to think about that for a second and let me put it in perspective. Okay, so this is a cancer statistics for African Americans. It comes out every couple of years, and if you look on the left and the right, on the top, that's talking about the estimated new cases that they expect each year. And if you look at it, for men, prostate is more than twice the rate of new cases each year than lung cancer. And if you look on the right, you'll see breast cancer, almost twice the rate. Go down to the bottom half, the estimated deaths that are going to occur, and look what happens. Lung cancer jumps up. So even though you have twice the amount of cases of lung cancer coming each year, more people are dying than any of the other of the types of cancers that are available. So there's something here about it, especially for African Americans, of why are more dying from, even though it's significantly less than some of the others of prostate or breast cancer. And there's several factors that play a role in that. So I mentioned a little bit about the smoking and the susceptibility to tobacco smoke. And we need to get this, have a good understanding of this. Okay, so on the left-hand side, I'm showing that the lung cancer incident rates, right, or the frequency of lung cancer per 100,000 people. And if you look at African Americans, it's about 74.7, which is pretty significant. That's high, okay? Whites, 64, and then Native Americans and Alaskan natives is about 49%. Now, let's take the comparison though, right? Because you have if you look there on the left-hand side, African Americans about 17% more likely to develop lung cancer, right? Go across and to the other side and let's look at smoking prevalence, okay? So then let's look at African Americans and look at whites. And those are pretty much equal. For the men in the yellow and the orange is the women, almost equal, and maybe a little bit less for women compared to whites. But even with that, they're 17% more likely to get the lung cancer. And then look at Native Americans, especially the men. They're smoking, right? 42.3. But still, they have the least amount of lung cancer incidence, the lowest amount of lung cancer incidence. So what is this telling you? And you guys see this. You know, you can see this right there. That's telling you that it's not just the smoking alone. There is the susceptibility, the effects of the tobacco, the nicotine, the other products that come out of tobacco smoke that lead African Americans to having a higher rate of lung cancer. So I say this because a lot of times when we talk with our patients about lung cancer and we want to focus in on this and we ask about smoking, people get a little, feel like a little guilty, right? They feel like there's a little blame. Like, I've done this to myself, you know, I've been smoking. This is something that's my fault. It's a factor that contributes to it, but it is not the sole reason, right? There's another thing that we need to know about our bodies and our race that make you more susceptible to tobacco smoke and increase this risk. And the numbers show that. Okay, so shift a little bit because I got to keep moving. I will run long. Okay, is health care. Okay, so you empower people with knowledge about they might be more susceptible to tobacco smoke and how do we approach that? And you think, how does the healthcare facilities attack that in terms of early detection and screening and systemic factors? And where do some of these disparities arise? Well, the first one here, and this is one really kind of hit home when, especially at Grady, but African Americans are less likely to meet screening eligibility criteria compared to whites. Okay, so talk about this. So what is screening? And we all know, we know about prostate screening, we know about colon cancer screening, we know about breast screening, okay? Screening is very simple. You're checking for cancer before there are any symptoms. Because what you're hoping to do with any type of screening is find the cancer before it's spread. Find the cancer before it's caused damage, right? And so that's what screening does. And the way this is done for lung cancer is with a CAT scan. It's a low dose, not a lot of radiation CAT scan of the chest, which gives us a good picture of what the lungs look like. Okay. Okay. Reason that's important, tell you something about lung cancer. Most lung cancers develop long before there are symptoms. 75% of them do. Okay. So you may not have the cough, you may not cough up blood, you may not have the chest pain, but that lung cancer could be there growing unless you actually look for it. Okay. And by the time you have the symptoms of cough, coughing up blood, chest pain, other shortness of breath, 75% of those patients that are found with those symptoms have the late stage, stage 4, it's metastatic disease. So in order to get a head start on lung cancer, you have to get the screening. And there's 2 studies, won't go deep into them, but there's a National Lung Cancer Screening Trial which found that if you had this CAT scan over a chest x-ray once a year, that it decreases your rate of dying from lung cancer by 20%. And another trial showed it was by 25%, right? So that's 1 in 5 to 1 in 4 people that need to be treated that will be less likely to die from lung cancer. So if your doctor offers you the opportunity to get screened based on criteria, they feel that you have a criteria, you should take it. It takes about 30 minutes of your day, 1 time a year, unless they find something. And if they find something, then the approach should be a very aggressive, figure out what it is, no delays. But 1 time a year, 30 minutes, and I'm sorry, women, if your husbands or your significant others are smoking and we know we don't like to go, we need to go. You need to push us in there, right? Because this lung cancer affects African Americans much worse than any other race, and I'll show you that shortly. Okay. So who should be screened? If you don't know this and you know someone that has smoked or you yourself have and whatever else, you might want to write these down. Okay. If you are between the ages of 50 and 80, if you have at least a 20-pack year smoking history. So what does that mean? 20-pack years means that if on average I smoked 1 pack a day for 20 years, that's a 20-pack year smoking history. If I smoked half a pack a day for 40 years, that's 20-pack year smoking history. So if you smoke that much, right, no blame, no shame, you should ask about screening. And if you have quit or still smoking or have quit within the past 15 years, you can still qualify to get screened. If you quit 16 years ago, you're good, right? But if you're within that range, you should ask about it. You should be offered about it, because the only way you're going to catch it early is if you get the screening. Okay. So a lot of words up here. Let me run through this. And the reason I bring this up is because this is a study that we published in the literature that I think triggered a lot of the recognition of some of the disparities for lung cancer screening in African Americans. Okay. And so what I was noticing when treating patients is I would get patients 29 years old, 34 years old with stage 4 lung cancer, right? Beyond the opportunity for cure, all African Americans. And then the amount of smoking was very little. And I said, there's something wrong with the screening criteria that they're using, right? Because I showed you the new criteria. The older criteria is you had to be 55, and the older criteria was that you had to have a 30-pack year history. But what I found out, just by looking at our patients at Grady, is 16% of them, of the patients that we knew had lung cancer, would not have even qualified to get screened. All African American. No, so this is what 11% of the African Americans who had lung cancer didn't have a chance to get screened because they were too young. Another 5% were above the age. So we were missed out of the screening criteria. Part of that is not participating in the clinical trials, because when we don't participate in clinical trials, the data doesn't reflect our population. And when it doesn't reflect us, we don't get the same amount of screening criteria, we don't get an equal level of treatment options. So then we went and looked back and we looked at all the cancers, 468,000 cases throughout the United States. And it was similar. It's about a 14% difference. And what we found out is what happens here in Atlanta at Grady Hospital, where we were doing this, is equal or represents what's happening for African Americans with lung cancer across the United States. There was another study, I won't spend long on it, but they also found out, this is Dr. Aldrich, she's in Tennessee, they found that tobacco use was less for those patients, for African American patients that had lung cancer. So that's why they changed the amount of pack years that you had to smoke. But we already knew that from 2008, from that data that I already showed you. So this is why the changes came from that, because the screening criteria that they applied, that's supposed to apply to all, wasn't applying to our patient population, wasn't applying to us in this room. African Americans are usually diagnosed at a later stage. And people say, well, that's because they don't go to the doctor. No, that's not the exact reason. Because even when we look at those people, we take this is data looking at the stage at the time you were diagnosed. I'm going to break this down very simple for you. The localized means you have lung cancer, one spot, right? Stage 1, maybe 2. Stage 1, easy to treat. Easiest treatment, surgery. Cut it out, get it out of the body. Don't let it spread. Stop smoking. Don't increase your risk of getting another one. Okay. Regional, I mean, you might have the one spot, you might have some lymph nodes centrally, but it hasn't gotten outside the chest. Still easier to treat. Distant, you have cancer here, cancer here, cancer here, cancer here. It's spread, right? It's too late. Okay. Blue is white. Blacks are, the red is blacks and African Americans. And look at this. Earlier stage, we're less. Regional stage, we're less. Distant stage, we're higher. A lot of these factor into a lot of the other components that I talked about. It's not just health and it's not just health care. It's a combination of them impacting us all. And it gets worse, right? Because there's a lower likelihood. There's a lower likelihood of receiving the standard diagnostic treatment, staging, and care, right? So this is really important. This is where you need to be empowered, because if you get diagnosed with lung cancer or the suspicion of lung cancer, your time clock starts ticking right there. You need to get in, find out, and get treatment. And our goal is to try to get all this done at Grady within 30 days, okay? That's our goal. I know this. Personally, my father had a spot on his lung. He called because he knew this is what I did. I said, let me speak to your doctor. Oh, my doctor knows you. I said, okay, you tell him what needs to be done, and this needs to be done. We need to stage, we need to get the CAT scans, you need to get a biopsy. And when they found it was lung cancer, I told him, you can get the surgery. He said, oh, I don't want to get the surgery. They cut me, it's going to spread me, whatever. No, it's not. You need to get the surgery. Okay, that was 4 years ago. My dad's still with me. So. But it is important that we know this. It's really important that we know this, because if we talk about the invasive procedures to diagnose and to stage, and you look at the predictors for undergoing the invasive procedures, these are the categories. Now, a lot of medical journals and stuff like that, the OR, that's the odds ratio. So some people that are like, have their little bets on the Super Bowl tomorrow, they know this. The OR there, okay, if your OR is 1, you're even kill. If you are less than 1, then you are unlikely to get the appropriate procedures to diagnose and treat. If you're above it, you're more likely. Look what number 1 is, black race. Less likely to get staged and diagnosed. If you go to the doctor and you say, okay, how are we going to move forward with this? How am I going to get the scans? How am I going to get the biopsy? And they say, well, we don't have this here. Find another place to go, right? Because you have a time clock. You have about 40 days before that cancer will spread to get yourself diagnosed and then move on to the proper surgery or treatment, especially if it's stage 1, right? Surgery is what you want. But look again what happens. Of all the races, black race stands out. You are less than almost half as likely, 0.55. You're nowhere close to 1. All the other factors don't really play as big of a role as just the race alone. So this is where we need to be empowered with the information and be able to go back and speak to those professionals that are going to help us get through this. This is where health literacy empowerment works. So this is, I mentioned a little bit earlier, stage 1, easiest to treat. Cut it out, get it out of the body, right? Just give you the quick on this right here. So who is likely to get curative surgery for lung cancer, to get it out of the body and to be cured? Whites, blue, white male are blue, black men, red, white women, green, and black women, yellow. And so if you look at those that had stage 1 and how likely they were, men, we have a problem, right? Only 65%. And this is for potentially curable. But what we do know from other studies is and this is a study looked at 22,000 patients with lung cancer, right? And they were saying, okay, what if you tease through all of this information and you found all those, you took a comparison of everybody who had stage 1 and how often they got to surgery and did that and compared to races. Well, here's what the overall looked like. So real simple. On the left-hand side, you're going to see that's the survival, right? The likelihood or what percentage are surviving over the time. So they talk about the 5-year survival or 50% of people still alive, whatever. You'll see that all cancers throughout the whole study, African Americans were faring less. At 5 years, less were more likely to be alive. If you move over to the right-hand side, and for those that had stage 1 and they got equal surgery, equal treatment, blacks got equal treatment as whites, the survival curves were basically the same. If you get equal treatment, your survival's equal. This is so important for us to know and what to ask for when it goes to getting treatment and being empowered to ask the proper questions. Biomarker testing. This is going to be the new direction for lung cancer coming forth. So if somebody's diagnosed, or you know somebody diagnosed with biomarker test with lung cancer, you need to ask them about biomarker testing. Because before, the standard treatment is either surgery, chemotherapy, or radiation, and not all one treatment made the same outcomes for everybody. One shoe didn't fit all. But now what biomarker testing does is they will test for genetic mutations of the cancer, and they can target how the cancer grows, how it spreads, how it invades or creates its own blood supply. And now there's about 35 new treatments that target each aspect of that and be able to treat cancer better. And it improves survival. And it can be by blood work or just taking some tissue from the biopsy and being able to determine which new treatment is going to give you a better outcome. Okay. So you need to ask your physicians, can I get biomarker testing? And can it lead to targeted treatment specific for me or specific for my loved one, that they can get a better outcome and survival, right? Different markers to test for. You can take a picture if you wanted or something like that, but you just ask them about biomarker testing, because if they don't offer it and they don't offer the treatments, consider going to a specialized center that does, because the treatments are out there. And only about 14% of Black patients with lung cancer receive biomarker testing versus 26% of whites, right? But this is the new equalizer, right? Because chemotherapy can be hard on the patient's body. The radiation can be hard on the patient's body. Sometimes these are just pills, right? Or once a month treatments, right? And they're training your body to attack the cancer from stopping it from creating its own blood supply, from spreading, and from multiplying. So there's different ways that are less toxic and allow people who may be a little bit more frail to get treatment and extend their lives. African Americans at the highest risk for lung cancer, okay? Screening missed a lot of African Americans in the beginning, but of these data that we put out, these studies that were published, shifted the staging criteria, got them to move back and include us more. We just need to get into the staging process. So if you know somebody that's a candidate, or if your doctor offers you the opportunity to be screened, take it. It's 30 minutes once a year, and it can save your life, decrease your rate of dying from lung cancer by up to 25%. Okay. And then structured treatments. If you're diagnosed or you know someone diagnosed, ask about biomarker testing, because we know that equal care can give you equal outcomes. African Americans, especially men, never too late to quit. Never too late to quit. Thank you. Okay, so we'll go here, then we'll go here, and we'll go back. Okay. Go ahead.
Yes, how does secondary smoke impact you if you live in a household with somebody that smoke and you don't smoke? How does that impact that individual?
We do know that, especially in our population, the susceptibility to smoke is already there. And sometimes the secondhand smoke is a little bit worse than what's coming out. So we do know that it does impact. The problem that we have is it's hard to tell exactly how much people are being exposed to. So because you don't know if one person is smoking, half a pack a day, 2 packs a day, whatever else, but it does play a role. And sometimes we see that if we said someone that says, I've never smoked, but I have lung cancer, we come back and we look at them and say, okay, yes, but did someone in your house smoke? That plays, gives you a different, idea about how they may have developed the lung cancer.
Dr. Fladell.
Yes,
Do
ma'am.
we know if the insurance companies are paying for the yearly low-dose CT scans?
If you meet the established criteria, which I was showing early, 50 to 80, 20-pack year smoking history, you've smoked any time within the past 15 years, then it is approved by CMS and Medicaid, Medicare. They should be covering for it because it's preventative. And if you mention them, they give you pushback. You say it's cheaper to get screened and not have to pay for chemotherapy. Yes, ma'am.
Hello, I know it's relatively new, but is there any research on vaping and the things that come with vaping and cancer, lung cancer, specific to the African American community, and men in particular?
Yeah, so the vaping, we've already seen that it causes a variety of other types of lung injury and disease. The link specifically to lung cancer has not been made. There's other damage which causes inflammation, which causes scarring of the lungs, and we know those actually contribute to the development of lung cancer, but it's still new. We haven't really figured out how much. What I will say about smoking, and when you talk with your doctors, this blame thing, this feeling of guilt needs to go away, and you need to be open and honest about how much you smoke. So a patient come in, he says, oh, I only smoke 1 or 2 a day. And I asked him, I said, what do you smoke? And he was quiet for a minute. He said, I smoke a few things. But when I say 1 or 2 a day, it's black and mild. I'm not smoking cigarettes. It's not packs of cigarettes. Let me tell you, one black and mild is about 1.5 packs of cigarettes. People don't know that. You can look this up. One big cigar, maybe 2.5 to 3, right? And if you're smoking that a day, so I told him, I had one patient tell me he smoked 4 a day, and he'd been doing that for 10 years. I said, you're 30-something years. You have a 40-pack year smoking history. That's why you have your lung cancer, right? So we need to, this knowledge, this empowerment is going to help you go out, because the best thing to do is prevent and quit. Don't let the young ones start. Yes, ma'am.
With the criteria for getting tested, if you've never smoked, no one in your household smokes, but I have a sibling that died of lung cancer. So do I have to meet all the criteria or just the 50 to 80?
You would have to meet the criteria in order for it to get covered. Now, when you speak with your physician, you can mention to them that you had a sibling. Was your sibling a smoker?
No.
No. So you mention that to your healthcare provider, your physician, and you let them know, I had a sibling that died of lung cancer that was a never smoker, right?
Okay.
Because then they can at least get an x-ray and kind of screen you. They won't be able to get the CT scan without it being covered, but the x-ray they can get.
What about the biomarkers?
The biomarkers would be more useful. They haven't become a part of the screening process. There's studies going on to see if we just draw blood work and find it and then screen that person, but it hasn't happened yet.
Okay.
So you wouldn't give up an opportunity for biomarkers until there was a diagnosis of cancer.
All right. Thank you.
Question? Yes, ma'am. Yes, ma'am.
Hi, thank you so much. I kind of have wanted to piggyback off of her question in mentioning, some of the qualification and eligibility for screening, CAT scans. Are there any, if you don't necessarily meet the traditional criteria, or if you're a lot younger than, what is, I guess, traditionally used to be covered for the CT scans, are there any resources or advocacy groups that you can reach out to if you feel that your insurance provider or just people that are supposed to be taking care of you in health and just kind of not listening to you when it's some of those things?
Your primary care doctor can then, if they document appropriately in the charting of what their risk factors are, they can go for it. So they would ask you, is there a strong family history of it? And the reason that is because even though there's the hard criteria, CMS and Medicaid, Medicare, they kind of have a 10% deviation from the standard criteria that the hospital won't be dinged for screening outside of the guidelines. So they can vary 10% for specific patients at other high risk factors and go from. So that would be a discussion with your doctor about whether or not you would fall into that 10% category of receiving.
So I think I get the last question. So to build on your comment about Blackie Miles, could you really speak to the impact of menthol and other flavored tobacco products, which are often consumed within African American and Black communities?
Yes, these companies knew what they were doing, right? Flavor it so that it's more, yeah. And even look what happened with vaping, right? You give flavors that are more desirable to different populations, you know, candy flavors to kids, menthol to African Americans. So that does play a role. And then take Black and Milds and just listen to the name.
Right.
But it ain't mild. No, it's a pack and a half of cigarettes in one of them. That's the last question. Thank you very much.
Okay.